the bill. We are rapid antigen testing for all staff, designated care partners. All staff and visitors in the home are wearing, well, staff in general and designated care partners are wearing surgical masks all the time and N95 masks when the risk assessment and condition warrants. And I'll talk a little bit about that later. And we continuously monitor our PPE supply and are ready to move in to full outbreak protocols as needed. So there have been many updates and new directives from the Ministry of Long-Term Care. We've received updates on December 14th, 23rd, 28th, 30th, and January 4th. These updates have outlined temporary enhanced measures due to the increased number of cases as a result of the new variant Omicron. The new measures have affected a number of things, including vaccinations, surveillance testing, visiting, leaves of absence, resident activities, IPAC measures, and third and fourth dose vaccinations. We had actually implemented many of these enhanced measures on December 24th and December 26th ahead of the provincial direction. We have seen a significant surge of COVID cases both provincially and locally. Unfortunately, with this surge, we're seeing more and more long-term care homes in outbreak. Today, the Ministry of Long-Term Care is reporting 186 long-term care homes in confirmed COVID outbreak. Yesterday, it was 145, and on December 31st, it was 98. So it's changing quickly, and it's rising quickly. Many homes, like ours, are experiencing our first outbreaks that include residents testing positive with COVID-19. We have, however, been preparing for this for almost 2 years, and we now know more about testing, transmission, and infection control practices that allow us to contain and control an outbreak. So I'll give you an update on the kind of the lay of the land in terms of outbreaks across the 3 long-term care homes. On December 22nd, Rockwood Terrace was confirmed to be in a COVID outbreak. Karen and her team have done an amazing job of managing this outbreak, and we've been providing daily updates to the Rockwood Terrace residents, staff, families, Dcps, and the community. Karen is going to provide an update, but before I hand it over to Karen, I'll just talk about the other 2 homes. Lee Manor has also been doing a great job managing a respiratory outbreak that started on December 27th. It has been since identified as a seasonal coronavirus, which is a common cold, a common bug that often floats around seasonally, and we know that it is different than COVID. It's not the same as COVID. That outbreak has been contained to the 2 South home area. Through our regular COVID surveillance practices, rapid testing, monitoring for symptoms, so both residents and staff are always, we're monitoring the residents and staff, we're monitoring ourselves. Our staff notifying us as soon as that they've been informed of being, having an exposure in the community, we have found positive COVID cases in staff. As a precaution and working with public health, we have enhanced our surveillance measures with additional testing for all residents and staff living on 2 South and 3 South home areas. Those results are still pending. We're regularly checking in with our contacts at the lab in London. The labs all across the province are working as hard as they can around the clock to work through the backlog of thousands of PCR tests. When our tests go to the lab, they are well marked as long-term care samples and they are prioritized. The labs are striving to get back to the 24, 48-hour turnaround for our tests. Grey Gables has also been actively following the COVID surveillance measures and working through increased situations of staff who are high-risk exposure or symptomatic or have had a positive rapid test. Today, Public Health has declared a suspect COVID outbreak on Maple Lane. There is currently 1 symptomatic resident that's in isolation. The resident has been PCR tested and we're waiting for results. 1 staff member has tested positive for COVID and is self-isolating. 3 additional staff members have reported symptoms and have been tested and are isolating at home. And a 4th staff member had a positive rapid test, and so they've had a PCR test and they're isolating at home. After Karen gives her update, I am going to go through the process and what happens for residents, staff, and DCPs when you may have symptoms or test positive on a rapid test. We're going to go through that. But before we do that, I'm going to pass it over to Karen to give an update on Rockwood Terrace.
Thanks very much, Jen. So as Jennifer mentioned, we did unfortunately enter into a COVID outbreak on December 22nd, which probably isn't a surprise to most of you with the daily updates. Total cases to date include 12 residents and 8 staff members. And as of now, only 1 resident remains active, and that is on 3rd floor. And 3 of the 8 staff members remain active. We have numerous control measures in place, including personal protective equipment for the team members as well as visitors. We have visitor restrictions in place. We do continue testing both residents and staff members every 3 days. We have moved to tray service for both 2nd and 3rd floor. Group programs have been canceled. We are doing staff cohorting. We are completing infection control audits and educating as we go. Social outings have been canceled, and we are utilizing HEPA filters in areas as designated. We do have daily outbreak management meetings with that include representatives from public health. Our medical advisor, Dr. Pillish, participates, as well as staff here at the home, and Jennifer and Denna from the county. Members of the leadership team have been on site 7 days a week since the outbreak started to assist with meal service. Currently, we're able to secure all supplies needed. Staffing, while it was strained at times, especially over the holidays, is becoming increasingly more stable. Residents that provided consent and have qualified have received their 3rd dose of the vaccine. And I would just like to thank all of you designated care partners for your support, not only physical, because some of you came to the home and helped to assist your loved one with meals, but also the many words of encouragement we have received. I would also like to send out a special thank you to the Rockwood team for their dedication and support during these extenuating circumstances, and also provide a shout out to Grey County staff, many of whom were side by side with us over the phone over every day of the holidays, including Christmas, for support provided. And especially to Denna, Jen, and Tolleen. Back to you, Jen.
Thanks, Karen. I just can't emphasize enough how strong and committed every member of the team has been and continues to be at Rockwood Terrace. And that includes the DCPs and the residents. So thank you. Thanks for that. A lot of information has been coming at all of us really quickly, and some of it is new and some of it isn't. So I'd just like to go over what happens when someone is positive with COVID. So for residents, if a resident has even 1 symptom, they are assessed by a nurse and are tested with a PCR test. If the test is negative, they continue to be isolated until their symptoms resolve. If the test result is positive, public health is notified and provides direction. Under the current Ministry of Long-Term Care directive, 1 COVID positive resident triggers public health to declare a COVID outbreak. The resident continues to be isolated and monitored by the physician and the nursing team. Public health assesses the situation and provides direction on further testing required. IPAC measures beyond those that are already in place, such as cohorting, any changes to PPE or isolation practices. Every outbreak is handled slightly differently depending on the circumstances, but often residents and staff in the home area are all tested. That provides us a picture of how many people may have COVID with no symptoms, asymptomatic, and who doesn't have COVID. Then we're able to cohort, move positive residents with positive residents and negative residents with negative residents. In Rockwood Terrace's case, we test everyone every 3 days, and this helps us to identify any new cases, perhaps adapt or change our measures that we have in place. Karen mentioned the daily outbreak management meetings that happen, and that gives a really excellent opportunity for us to check in and make sure that everyone's on the same page. Are there any background things that need to be done behind the scenes, that kind of thing. We have been providing and will continue to provide daily updates to residents, staff, designated care partners, POAs, and powers of attorney, and also through our newsletter email that comes via MailChimp. So for staff, if a staff member has symptoms, they notify the home. We provide a PCR test, often in the parking lot, and they go home to isolate while we wait for results. If the test is negative for COVID, they return to work when their symptoms have subsided. If the result is positive for COVID, they will remain at home for 10 days. If a staff member tests positive on a rapid test, we do a PCR test and they go home to isolate while we wait for the results of the PCR. If the test is negative and they have no symptoms, they can return to work. All of these situations are handled on a case-by-case basis with discussion with public health to ensure we're looking at exposure timelines and all sorts of factors. But I just wanted to give a bit of a general overview. If their PCR test is positive for COVID-19, they remain in isolation for 10 days. Our public health representative that we work with on a daily basis must approve a staff member's return to work if they've been COVID positive. So we discuss this on our daily outbreak management calls. Designated care partners. They follow the same process. You will follow the same process as staff members. If you have symptoms, contact the home and we'll arrange to provide you to do a PCR test for you. If you test positive on a rapid test when you're visiting, we'll do a PCR test. In both of these situations, you'll isolate at home while you wait for results. As long as you have symptoms, you should isolate at home for 10 days. If your PCR test is positive, you'll continue to isolate for 10 days. When public health contacts you, it's important to tell them that you're an essential caregiver at a long-term care home. We will touch base with you to confirm the last time you were at the home and just to confirm that there were no IPAC breaches, no slips with the mask or any other PPE that you might have been required to wear during your visit. This helps us to know if we need to test anyone else in order to contain any possible spread. So in some cases, depending on the time frame of your visit, we may also swab your loved one that lives at the home. There's been a lot of talk on the news and even in this update about the change in isolation period, everything from 5 days to 7 days to 10 days. This guidance has been updated and allows for a shorter isolation period as an option for essential healthcare workers. However, the recommendation for long-term care staff is still 10 days. It can be shortened to 7 days, but only on a case-by-case basis with approval by public health and requires additional rapid testing as part of the shortened time frame. At Grey County Long-Term Care, we have made a decision that we will not be using the shortened 7-day isolation period unless we are in an emergency situation where residents and staff are at risk due to critical staffing shortages. If we trigger this emergency response, it will be communicated to residents, families, DCPs, and staff. We will exhaust all other options before making this critical decision. As I mentioned earlier, we implemented enhanced measures on December 24th and 26th, and I want you to know it was a very difficult decision to do that the day before Christmas, and I really appreciate your support. So the measures that continue to be in place: all resident outings have been suspended. General visits, indoor and outdoor, are currently suspended. Essential visitors are still permitted for palliative or critically ill residents. Designated care partner visits have been reduced to 1 DCP per visit at Rockwood Terrace and on 2 South at Lee Manor. 2 DCPs per visit are permitted everywhere else, so the other floors and home areas of Lee Manor and Grey Gables. Virtual visits can still be arranged for all residents at all 3 homes. Window visits can be arranged for Lee Manor, all home areas excluding 2 South, and Grey Gables. We are using N95 masks when a resident is in isolation and when a home is in confirmed COVID outbreak. Staff are mask fit tested to ensure that the N95 mask that they're wearing fits them properly and offers them the proper protection. We have been providing N95 masks that do not require fit testing to designated care partners who are visiting a resident who is in isolation or in a home area that is in confirmed outbreak. Let's talk a little bit about vaccines, boosters, and 4th doses. Effective December 31st, boosters or 3rd doses of COVID-19 vaccine are now mandatory for all staff, students, volunteers, and designated care partners. Everyone who is eligible now for their 3rd dose must have it by January 28th. If you're not currently eligible for your 3rd dose by January 28th, then you must have your 3rd dose by March 14th. Residents of long-term care homes are eligible for a 4th dose of an mRNA vaccine if it's been at least 3 months since their 3rd dose. There is a limited provincial supply at this time of Pfizer, and the county has access of Pfizer doses on a limited basis only. Remaining Pfizer has been allocated for staff under 30. So the mRNA vaccine that we have most supply of is Moderna. DENA has created a vaccine booster 4th dose information sheet, and we will be including it in the follow-up email because there's a lot of dates and details that go with this information, and it's nicely put into one page. So we'll send that out with the follow-up email. The teams in the homes are actively working on creating as many opportunities for vaccine clinics at each home as we can support. So we really need to get 3rd doses into all of our eligible staff and DCPs before January 28th. And the teams have already been doing the behind the scenes work to get the 4th dose information in place for residents. That, I think, brings us to the end of the update. So Rob, we can go to questions.
All right, thank you, Jennifer. And I do see that we have some good ones sitting in there for us already. So if you do have any questions, please do put those into the Q&A and we will work our way through those. And if you're having any issues with the Q&A section, just drop it into the chat. And as well, to those of you that are calling in, if you have any questions, you can always email them to communications@grey.ca. And we will make sure that we forward those on to the team if we can't answer them ourselves, and we will get back to you on that as soon as we can. So our first question tonight is regarding exposure. What constitutes exposure when answering screening questions? Are we exposed just by being in the home where there's an active COVID case?
That is a great question, and I'm going to turn to Dena to help answer that one.
Yeah, I think especially with community spread and public health not following up on case and contact management as they were with every case, identifying if you're exposed or not exposed has a lot to do with what happened with you in the community. Who have you heard from? Have you been contacted because now cases are notifying their own contacts? Have you been notified with that? In terms of coming into the home, if we certainly are working towards all of those measures of, screening is one of the tools, the rapid antigen testing that you do coming forward, wearing your PPE for DCPs, just going directly to their loved one's room. All of those things limit your exposure. But if you were identified in the home as a close contact, as Jen alluded to, we work with public health. We take a look at who is there. That's why we ask in the screening question, who are you here to see? When you sign in those cases, and we identify it. So exposure is a bit complicated. So we definitely want to encourage people to limit their exposure out in the community and through those public health measures. And when you're in the home as well, limiting exposures, we're encouraging people not to gather, visit with their person. And I'm hoping I've answered that. Maybe there's a few more. Go ahead, Jen.
No, I'm going to just do a follow-up question to you. So when someone comes to the screening table and they're asked that question, have you, and I'll probably get it wrong, but related to exposure, the main things to keep in mind are, do you live with someone who has tested positive or has symptoms?
Mm-hmm.
So if someone in your household is sick but hasn't had the opportunity to be tested because of the changes, we are now being told to assume that if you have cold-like symptoms, it's probably COVID. Mm-hmm. So if someone in your house that you live with is ill, then that would mean you have exposure. If you've been contacted by text, perhaps by public health, or they've phoned you to say we believe you're a high-risk contact, that would be exposure. Is there any other examples that might help someone, or are those kind of the main?
Yeah, I think, and if in doubt, our screening tool does pull a lot of that forward. But if you're in doubt about whether you've been exposed or you've heard, maybe just to pause until you get a bit more information. So for example, if you think, well, I heard my neighbor might have had it, but I hadn't heard, that might be, and we just had coffee, that might be an opportunity to just pause and think if maybe we just wait a bit to get a bit more information. We are obviously discouraging visits where there's any potential risk of exposure. So, but yes, if in doubt, just ask, and we'll help you work through that risk assessment about exposure.
Thank you both. And just a little bit more to that for a question a little further down here. If a designated care partner does have a positive case, or they have that close contact, how long are they away? Are they required to stay away then from the home? And are they required to notify us that they have had a positive case, or that they are positive?
Yeah, I'll just jump in. We received, and I happened to pull it up there, we received some guidance from the Ministry of Long-Term Care, and it says, I work in a long-term care home, and this also includes our designated care partners, and tested positive or was exposed to a presumed or confirmed case. And Jen alluded to that, in terms of, because we're not PCR testing anyone, everyone at this time in the community, then you're presuming. So yes, we want you to, if you've had that notification, notify us right away, and we'll help you work through that. And we'll also help you to get tested if there's an exposure. But the intent is that you would be isolating for the 10 days if you either have COVID or you've been exposed to a presumed or confirmed case. And we, again, have that algorithm to help walk you through it.
Okay, thank you for that clarification. A comment here regarding the new N95 masks that we are offering to designated care partners. It sounds like there's been some trouble with this individual as far as comfort and fit, and some difficulty for them breathing with the masks on. Are we fit testing designated care partners at this time? Is that something that may get better when we do that process? And are the N95s required for DCPs when they come into the home?
So I'll start with, are we fit testing? We haven't, we just don't have the capacity right now to do fit testing for DCPs. I do think it's something that we should build into our process moving forward when we're out of this surge. I think it's something that we should consider a part of the orientation process of being a designated care partner. But during this surge, we just don't have the capacity to coordinate that. We have, I think we have over almost 500, if not more, designated care partners across the 3 homes. And so we just don't have the capacity to even sort out how we would do that in a fair and equitable way. So we have looked for this other option of the N95 masks that do not require fit testing. I have reached out through Ontario Health to see if they will provide additional non-fit tested masks to add to our supply, because it is very difficult to source these right now. In terms of, are we mandating it? I think the important piece is that the N95 adds protection for the person wearing it. So the surgical masks, when we started with that, the surgical masks protect the resident, the person you're providing contact with. The N95 protects you and the other person. So if you're in a space that is a COVID outbreak, we want to offer the most protection that we can. So Dena, is it mandated per se for the designated care partners, or we've just offered it because we want to make sure people have the most safe options available to them?
In terms of what the ministry has said, is that that we can, if certainly we're not mandated to offer, but it is encouraged, and we have been supporting those who brought their own N95s, as long as it isn't the vented ones. Those are the ones that we've certainly do not want, the vented N95s or the KN95. So we have been supporting that. The ministry has encouraged us to do our best, if N95s are not available, to have as tightly a fitting mask as possible. So at this time, we're not mandated for DCPs, definitely for our staff, based on occupational health and safety requirements, and certainly the requirement that they need to be providing direct care, but not at this time. We're certainly doing what we can with the efforts and the supply, as Jen alluded to, and maybe if you could speak to where you could source it. There's some community sources out there that maybe you can purchase on your own, and if that's something we can do to be a better fit, we'll see if we can support that as well.
Okay, thank you. This question is regarding staff returning to work. So you mentioned that there's the 10-day isolation period after a positive test. Do they require a negative PCR test to return to work under the new framework?
No, not at this time. In actual fact, it could continue to detect small amounts of virus, but it's inactive. And so PCR is not recommended to get out of isolation. Okay,
thank you. Okay. I think we answered these ones regarding what the policy is for people who have recently had COVID. It would just be isolating for that period of time and then waiting until all symptoms are gone.
It would. I'll just add, Rob, to that. If someone has had COVID, once they are returning to the home, their 10 days have passed, we would not do rapid testing for 30 days, right? They don't need to do the every other day of rapid testing for 30 days. And then after the 30 days, they would start back up with that process.
Okay, thank you for that. As a DCP, are we offering third vaccine doses at the home?
We sure are. So watch for emails and notices from your contacts at the home. If we can get that booster shot into you, we will do it. So yeah, watch for that. And we're happy to be able to do that to support this round of vaccinations.
And if you can't make our clinic date, certainly there's a lot of community hubs out there. We've shared, I think in our newsletter, I know a few emails went out to DCPs to advise about the vaccine clinic, as well as the community clinics that are being offered if you're unable to make it. But we are going to be doing this ongoing. So yes, Jen is indeed right. We will do whatever we can to support you.
That is great. This question is regarding designated care partners helping out in the home, and we do know how vital that role has been. What are the most important tasks that we could use DCP's help with? At Rockwood, we did mention around mealtime when we were having that extra stress on staffing. Should DCPs be helping with transfers and mobility to bathrooms if that's usually something that requires staff assistance?
So I'm going to pass it over to Karen because she may have some really recent experience with what DCPs have supported. So in terms of should, and then in terms of crisis, I think there's different answers. So in the before times and hopefully in the future times, DCPs would be able to help with things like transfers if they've had some additional training. And I can't even remember if any of that basic information is included in the current DCP training. Having said that, in very critical times, I know that there are DCPs who are very comfortable supporting with those kinds of transfers from bed to chair. If it's something that you're not comfortable with or that you just like a little bit of pointers, that's something that I think we need to figure out how to build in to some coaching and supporting in real time. And it's not a really great, clear answer, but I think when things are really tough, we need to figure out how to make sure people are getting the care that they need in the safest way possible for the resident, but also for you as the DCP. We don't want to put you at risk either. So it might be a bit of a different answer depending on the situation and the individuals. But in terms of other ideas, Karen, did you have anything that you wanted to add?
Certainly right now, meal times, especially for residents who need assistance to eat, is very helpful. We've also had DCPs do some personal care, such as shaving or assisting with brushing of the teeth. But certainly, as Jen alluded to, we certainly don't want you to put you in a situation where you feel uncomfortable doing something. So if you're not comfortable doing those things, we will make it happen with staff. So, but certainly, yeah, if you are comfortable, we welcome the assistance.
Thank you. Is there a point in our protocols when designated care partner visits would be suspended?
Doug, I'm so glad you asked this question because I love that I get to say no. They will not ever be suspended. Our commitment with this program was that we would never lock people out completely, restrict residents from their loved ones or loved ones from their residents. It's tough enough that we have to restrict it to one or two individuals, but our commitment has been that we won't, there's nothing in our protocol at this stage where people will be excluded completely from being at the bedside. We'll continue to make sure that as things shift and change, that we provide the education. If something changes and it looks like situation is changing in a way we couldn't imagine, we'll do what we did a year and a half ago and figure out how to provide people the training and the education and the information they need to be able to safely be at the bedside. So that's our commitment. I guess I should, my dad would say never, but that's our commitment, is to do all the things that we can to prevent that from ever happening.
All right. This question is wondering, are we able to share how many residents are not vaccinated?
Thanks. That's also a great question. And I was pulling up a chart, and I believe it's updated information from the end of December. So there's been significant efforts in making sure third doses are out to residents. So at the end of December, 98% of residents So about 97% across the 3 homes had their second dose, and 92% had their third dose, is an average across the 3 homes.
Okay, thank you. Are we still allowing new residents into Maple Lane at Grey Gables?
Okay, so that's a good question, and it's pretty timely. We had an outbreak management meeting this morning, and there was some discussion about that, and we're reaching out to public health for some more information and direction. We're waiting for some pending results, and we'll make a decision tomorrow when hopefully we get those results to be able to better determine. If some of the pending results are positive, it's quite possible that admissions will be paused on Maple Lane. If the results that we're waiting for are all negative, then it's quite possible that they will not be paused and we'll be doing an admission.
Okay, thank you. Just going back to exposure, further to the earlier question about, am I considered a close contact if I'm being in a home? If someone is a designated care partner in a Grey County long-term care home on a floor that does have active COVID cases, are they to be indicating that they are a close contact when they are screening for other purposes outside of our homes? Is that something we can answer?
So I think I'll flip to Denna, but I know she's going to say about risk assessment. So if you're at the bedside of your loved one and they have COVID-19 and you're wearing all of the appropriate PPE, it's not a high risk exposure. If you were not wearing any PPE, it would most definitely be an exposure. Where the risk assessment comes in is, where are you screening to go somewhere else? So if you were seeing your mom at Rockwood and then your dad at a retirement home, you might want to really talk it through with somebody in terms of the risk and the potential transmission. If you're screening to, I don't know why else people, I don't do anything anymore. I don't go anywhere. So I'm not sure where else you would screen, but those are the kinds of things to consider. Denna, is there anything?
No, Jen, you said it. It really depends, and we have to take a look at both what PPE you had and where you're headed. Are you headed for surgery? Are you, these are the things that we would take a look at. And often in the way things happen, when you find out, or sometimes your exposure was 48 hours before you even knew you were exposed, so some people, they do a trace back to 48 hours. So I think all we have to do is just do the best we can, disclose what we can, and let those folks work through the tools, recognizing what service or what option. It's tough. I know right now we're limited with where we are in step 2 in the province, but we do need to go to the grocery store, and as long as you are feeling, and you do need to go to medical appointments, but if they ask those questions, that's why those screening tools are there, whether you go to your physio, et cetera. And I think it's about the conversation and risk assessment indeed. So just tell them what you know, and we'll work through it.
Okay, thank you. Surgical masks don't fit snugly. Is there any way to tighten the sides of the masks?
Yeah, you sort of see those people with the ties that hold it at the back, and you're right, they don't necessarily fit as snugly depending upon the face. There's a multitude of surgical masks, but if you definitely want to take a look about no big gaps, make sure the really if the mask that we're providing, those surgical masks, really pinch at the nose, like truly that will provide a seal. And what it's trying to protect is any sort of exposure from the mouth or the nose. So definitely seal that area in particular. I have high cheekbones, and sometimes I notice that it comes, it's not on the side. I know some people are also putting on a second mask, and for that, they feel that protects a little bit. That's certainly an option for the 2 surgical masks. You can twist at the ear, but that also can bring up a bit of a gape. But I do think it's about trying to get the best fit. And that's where we go to sort of that the KN95s or the N95s, where it definitely does a seal. Then you do a seal check where you breathe to make sure it's so. But surgical masks are not as tight fitting as those KN95s or the N95s.
Oh, you're muted.
Sorry about that. So since you have just mentioned KN95s, are designated care partners allowed to wear KN95s in the home?
Yes, yes, you can. And in fact, like we are providing what we had available of the non-fit. If you have access to a KN95 or an N95 mask and it fits you and it feels more comfortable, by all means, you can wear that. You don't have to take it off to put on the one that we have. It's important to make sure, just like with surgical masks, if it's soiled, so it's wet, you need to change it. It's not effective anymore. And if that's the case, then you could grab one of ours. But if you have access to it, to a different kind, please go ahead and use that. They are hard to source right now. There's a few Canadian options that I could put the links, Rob, in a follow-up email.
Sure.
I have no connection with them other than I bought them for us here at home and for my daughter who works in a grocery market, and I make her wear it to work.
For sure, I will watch for that and we can include that in the follow-up. The staff that are self-isolating from Grey Gables, do they work on Mapleview, or can we say what home area they work on?
Yep, I can. We have done internal communications about this. So this has gone out to residents, staff, DCPs, and powers of attorneys. I'm comfortable sharing that 3 of the staff that we're waiting for results are linked with working on Maple Lane.
Okay, thank you. Can a DCP be in the room of their loved one who is COVID-19 positive, or if there are COVID-19 positive people in their home unit?
Yes, they can. And that's been going just fine, right, Karen? Yeah.
And then to confirm, DCPs are not required to provide proof of a negative PCR test?
That is correct.
Okay.
We may, if I may, if they've just recovered from COVID, and that's where they're thinking they may want to do a confirmatory PCR. That was an earlier question where we said it wasn't. We may ask confirmation when their positive COVID test was. And again, keeping in mind that public health is not necessarily following up on all case and contact, and that may have been done via text. If they weren't identified as a designated care partner, we may ask to look at the positive timing, because we have to be really assured that the 10 days have lapsed. So we won't ask for a PCR post-COVID, but we may want to inquire a bit more about to ensure that the 10 days have lapsed from the initial diagnoses.
Okay, thank you. Can an individual get COVID 2 times? Yes. At Rockwood Terrace, staff are being assigned to one home one floor or home area. Are the elevators designated for staff by floor?
Thank you for that question. I can answer that. Unfortunately, they are not. My understanding is because we have the 2 elevators, they can't be programmed to only respond to one floor. So we have no control over what elevator responds. However, with hand hygiene, the use of the PPE, and extra cleaning of those high touch areas, we minimize risk of exposure in the elevators. The other thing we have done is designate stairwells for staff, especially if they're walking down without a cart of some sort. We have designated the north stairwell for third floor and the east stairwell for second floor staff.
Okay, thank you, Karen. This one here. Please reconsider allowing designated care partners to wear AD safety N95 and not the ones handed out called Moldex. I'm not familiar with branding. I'm not sure if that means more to you, Dana or Jennifer.
No, it doesn't. And we're not restricting what brand people use of N95 or K95, with the exception of the ones that have the little vent. So if it has a vent, those are not allowed in the long-term care home at all.
Okay. Okay, this question, so this individual is double vaccinated, and unfortunately they did have COVID-19 over the holidays. They are wondering if, since they've had COVID, do they still need a booster? They are saying that they've spoken to a doctor who recommends not having the booster for 6 months. Do we have any background on that?
Yeah, I mean, I can jump in. When we did have we've worked with public health and asked the vaccine team for those that were tested positive for COVID, when could they get their booster? And, certainly the response from our local public health unit was obviously they have to stay in isolation and making sure they're well, because you have to be well enough to build up an immune response. And more recently, Dr. Karen Moore, who's our Chief Medical Officer of Health, has recommended that it be 30 days post-infection, where the suggestion is to build up a bigger immune response. 6 months does seem different to me, but I would encourage the individual to follow up with their healthcare provider to inquire about that time frame. 6 months is, as I said, doesn't align with either one of the recommendations I've heard, but there may be a reason based on that individual's health, in terms of, are they immunocompromised? Did they have any sort of outstanding health issues as a result of the COVID diagnosis that the family physician would like a little bit more time to resolve. So again, standard, Dr. Karen Moore said 30 days post-infection. And I would say, hey, call your doctor and ask a bit more about that rationale and to understand.
Okay, thank you. And if there is timing of overlap for some people, so there is that hard deadline that Jennifer mentioned earlier for the third dose, would this be one of those situations where you would want to seek out some sort of a exemption type note from your doctor?
I think that it would be best to start by reaching out to your contact at the home. So if it's the executive director or the RFSM or Dana and I, and we can start helping you work through what the options are in terms of your specific situation and your questions, and help just direct you to the right place.
Okay, thank you. Are there any supports to residents that are being minimized right now? For example, the 2 baths per week. I'm not sure if that's home specific, but just overall, is there a comment that can be made?
Sure, I can start, and then I can see if Karen has anything to add. So we always strive to meet and exceed the minimum standards in terms of care. When staffing is very strained, it can be a challenge. Historically, what we try to do is, if for some reason someone misses their bath, we try to bring in additional staff in the coming days and make that up so that people aren't going without. During the very strained time, particularly over the weekend, it is possible that I'm just making this assumption, Karen, you can confirm that it is possible that your loved one did miss their bath. Having said that, the staff provide head to toe care at the bedside. It isn't the same, but it is what they can in those really strange situations. And I don't know if I was reflecting that accurately, Karen.
Yes, I would say that is a true reflection. We certainly don't set out in the date and direct staff to provide baths. It's always our intention to follow the act, but staffing was at its worst, should we say. There were baths not completed.
Okay, thank you for that information. How many residents currently are there on Maple Lane that are COVID positive by a PCR test?
So there are no residents confirmed with a PCR test on Maple Lane. There is one resident who has symptoms who has had a PCR test, and we're waiting for that result.
Okay, great. Are N95 masks disposable or are they reusable?
I think there are both, but the ones we've been talking about are disposable.
Mm-hmm.
Are staff from one floor activity working on another floor, or do they have contact with other floors?
So I'll let Karen speak to this. A lot of efforts have gone into cohorting staff so that there are dedicated staff working with residents that have that had COVID. Many of them have now resolved, versus dedicated staff working with residents that had not tested positive to minimize that risk. Even staff rooms, right, Karen?
Yeah, so I was just going to say we even have designated break areas for staff working on second versus third, and have, to the best of our ability, kept the two separate. If on a rare occasion, and it wouldn't happen with direct care staff for sure, but maybe somebody like a maintenance guy had to visit both floors, they start with the floor that has no positive cases on it and move to, so start with the clean floor, shall we speak, and move to the affected floor if indeed it's necessary. But I say again, that wouldn't be direct care staff. They've been dedicated to one floor or another for at least their entire shift. We've tried to keep them there for all of their shifts. But if that's not possible, there's been a day or two off in between, then sometimes they have switched. But if it happens with support services staff, like I say, they're trained to go selectively from floor to floor.
Thank you. In the Rockwood outbreak, was that on floor 2?
So it started on floor 2, started with West Wing and some cases on East Wing. The North Wing was never affected, or not to date. On December 30th, however, the public health declared it on 3rd floor as well. And that's because at that time we had 2 positive staff that had worked on 3rd floor. And subsequently, we've had 1 positive resident on 3rd floor. So currently it involves both floors.
Okay, thank you. And we do have one more question in here, and it is saying, do you think medical exemptions are risky this far into the pandemic?
So it is definitely something that we take seriously and look at on a case-by-case basis in terms of what kind of support an individual with a medical exemption might be giving, what kind of interaction are they having or not having, and directly with residents. And so that is how we approach those kinds of situations and discussions.
Okay, thank you. Do we know what wing of the 3rd floor the positive resident is located on at Rockwood Terrace, Karen?
Yes, that would be the North Wing.
The North Wing, okay.
Yes.
All right, so I believe we have depleted our question bank there, and taking a quick look, I don't think anything came through the chat. So also looking at the clock, I think that has us at a good spot there. And okay, so we got a couple more coming through that we will try to get to here. Is there any consideration for hiring back unvaccinated staff with the shortages now? Now that vaccinated people are transmitting as much as the unvaccinated. So does anybody want to answer that one?
I'll just say that we continue to follow the ministry directives, and that wouldn't even be an option under the current ministry directives.
Okay, thank you. If only one resident has tested positive on the 3rd floor, can we assume it was transmitted to them by a staff member?
So no, I don't think that we can make that assumption. Residents have interaction with designated care partners as well as staff members. And at this stage in this surge, it's very difficult to determine whether any of, well, particularly staff to staff, is it linked with the outbreak and break rooms or interactions with each other, or are they completely unrelated and linked with the prevalence within the community? So at this stage, it's very difficult to make those linkages.
And if I may add too, we have really robust auditing practices. We have to follow during an outbreak weekly IPAC audits with Public Health Ontario, hand hygiene audits, PPE audits, doing huddles. So in terms of transmission, particularly at the height with all the PPE, transmission, and I certainly want to echo what Jenna said about the team, and in particular the work of Rockwood's team in limiting the transmission when you see others that were widespread, being able to contain, and that's what we say, keep it out of the house, early detect and contain. And so the containment has been exceptional, and the IPAC measures have been very sound. So, and the auditing that we're doing, not only that ourselves, but we bring in a third-party audit team as well, have said nothing but the effort. So I think that too helps us to know that the transmission at this stage of the game is quite limited, and it is difficult to assess given the practices are sound.
Okay. So that does take us past 8 o'clock. So if you do have any more questions that we weren't able to get to tonight, or if anything comes to anyone on the call after the fact, again, I just do remind you can always email communications@grey.ca, or you can reply to any of the newsletter emails that we put out. Those responses come to us as well. Send us your questions, and we will absolutely do our best to get back to you as quickly as we can with those answers. And it's also information that we can share in future updates to other people as well, because I always say, if you have a question, chances are someone else was thinking the same thing and just didn't put their hand up. So with that, Karen, Dena, Jennifer, did anyone have anything else that they wanted to add before we wrap up the call this evening?
I do just have some closing comments, and I see a last question asking about if anyone passed away. And so this outbreak has it has run the gamut in terms of symptoms or not symptoms and effects on people. So unfortunately, there was one resident who passed away of COVID during the outbreak. And our thoughts and condolences go out to the family and that individual's loved one, and also to the staff and the community. It was a very, very difficult circumstance. There also have been a handful of residents that had mild symptoms, and the majority of the residents had no symptoms. So it really has had a varying effect from all ends of the spectrum throughout this outbreak. So in closing, I want to thank everyone for your engagement in this meeting and lots of questions. Rob, thanks for hosting, and Dana and Karen, thanks for supporting with information and answering the questions. We are experiencing this surge of COVID that we were all dreading and working so hard to avoid, but it is here, and there's nothing we can do about the fact that we're in a surge. What we can do and what we are continue to do is dig deep and work through this. I'm hopeful that in a few weeks from now, we'll be on the other side of this. In the meantime, I saw a great photo today that everything isn't canceled. Sunshine isn't canceled. Relationships aren't canceled. Kindness isn't canceled, and hope isn't canceled. So thank you all for working alongside us as part of our care team, as cheerleaders and as advocates. It will take all of us working together, but we will get through these tough few weeks. So take care, be well, and thank you.
Good night, everyone.